So we're getting pretty.
Okay, I'm going to start recording. I'm just going to welcome everybody. To Division of Cardiology Citywide Rounds, a new era of heart failure management in Calgary. Before we get started, remind everybody, February is Heart Month, so a good month to be doing this. I'd like to thank Novartis and especially Justin Cooper for organizing this meeting. We have over 150 participants who have registered for this meeting. And just a quick shout out to Jeff Schaefer from Internal Medicine, getting his folks out there, and Alicia Nathan for getting the CCRN folk out as well. And also a thank to Dr. Murillo and the Division of Cardiology to allow this to be a Division of Cardiology event. We'll try to post the slides in the video after we're done. And just we have 4 really great speakers. My job as the chair of this meeting is really just to keep us on time, get through the questions, and I hope there's lots of questions. From my standpoint, I kind of consider myself to be an honorary heart failure doctor. I ran a heart failure clinic in the community for 10 years and previous director of the Rocky View Heart Function Clinic. And I've done a number of heart failure quality improvement initiatives, as well as started the care path at work that Jonathan and I work on with the new electronic medical record, Connect Care, which we have time at the very end we'll chat about. And I'd also like to thank Jonathan because he actually gave me a lot of these slides that I'm going to be presenting on. And before we get too far into any presentations, I just have a couple of quick housekeeping notes. First of all, please stay on mute for all of the presentations until the end. If you do have any questions, you can type them into the chat window. We're going to try to keep track of all of the questions and answer them in the Q&A session at the very end. If at the very end, during the Q&A session, you really want to have an oral question, then just type in the chat oral question and I'll say your name, and then you can go off mute and speak, because with over 150 participants, it can be a little bit difficult if everybody tries to speak at once. And then Justin's going to put in the chat window the evaluation. Please fill out the evaluation at the end. So that's all for that component. From the standpoint of the objectives, you've seen this already. Our objectives are to describe the current state of heart failure care in Calgary, talk about the upcoming Connect Care heart failure pathway and discharge supports, talk about the upcoming CCS heart failure guidelines update that is coming, and review and provide feedback to a very new and interesting way of managing heart failure called a cluster medication titration scheme for the treatment of heart failure with reduced ejection fraction, which is developed here in Calgary by your heart failure experts. So really looking forward to hearing the feedback on this approach. The quick review of this is really, I'm going to give you some background information. Dr. Nakul Sharma will talk about heart failure pathway and early continuity clinic. Jonathan Howlett will do that sneak peek at the CCS heart failure update. The sneak preview of the Connect Care heart failure pathway, I'll try to leave to the end so we can kind of move forward through the cluster medication and titration scheme for heart failure reduced EF. That's going to be presented by Dr. Nowell. And then Dr. Miller will walk us through a case example using this algorithm for managing patients. And then we'll have that roundtable discussion and hopefully end on time at 8:25. So here are your presenters, your faculty. I'm going to do a quick introduction of the faculty at the beginning, and that way we don't have interruptions. We just go right from one presentation to the next. The presenters did not know I went in the internet and just pulled up their pictures and found, I hope, the appropriate ones for them. Dr. Nakul Sharma, he did his internal medicine, cardiology, and advanced heart failure and transplantation at the University of Saskatchewan, University of Alberta, and University of Calgary, and has a master's in public health. He's a medical director of the Rocky View Heart Function Clinic and worked towards improvement of heart failure care in Southern Alberta through the use of order sets, pathways, and knowledge translation. Dr. Jonathan Howlett did his internal medicine, cardiology, and advanced heart failure at Dalhousie University of Toronto, and is actively involved in clinical practice guideline generation and knowledge translation related to heart failure. He chairs a number of national and international guidelines committee and is the co-chair of the annual Canadian Heart Failure Update meeting, which is happening this year, virtually, I believe. And he has over 150 peer review articles. Dr. Nowell did his internal medicine, cardiology, and heart failure, as well as echocardiography at the University of Western and the Mayo Clinic. He has a Master's of Science in Clinical Epidemiology and is the clinical director of the Libin Cardiovascular Institute, as well as the clinical and research director of the echo laboratories at the Foothills Hospital. He has a particular interest in infiltrative cardiomyopathies and actually wrote the CCS guidelines for the cardiac amyloidosis guidelines. And he has research support from the Heart and Stroke Foundation. Dr. Robert Miller is has internal medicine, cardiology, and advanced heart failure transplantation, as well as advanced cardiac imaging at the University of Calgary, Stanford, as well as the Cedars-Sinai Medical Center. And he's a medical director currently of the Nuclear Cardiology and Cardiac CT program in Calgary. And his research interests include advanced cardiac imaging in cardiomyopathies. So that is your faculty, whirlwind introduction, and there's certainly a lot more I could say, but we're trying to keep it brief. From the standpoint of a poll, I would like to just have a quick poll. And here's the question. The following cancers have a lower 5-year survival than heart failure: breast, prostate, colon, lung, or all of the above. So I'll give everybody just a minute if they want to do that poll. We got about 50 participants. I'm going to end the poll quickly because we want to keep going. And I'm going to stop the poll just so we can show the results. And what you see from the results is that the majority got it right: lung cancer. So I'm going to stop sharing that result and then move on to the next slide. You can see here heart failure, all of these other cancers, prostate, breast, and colon cancer, all have a better 5-year survival than lung cancer. And heart failure is right here below all of these other cancers. So we really have a lot of work to do, definitely, in the treatment of heart failure. And what we know about heart failure is there's 600,000 Canadians with heart failure, 50,000 Canadians developing heart failure every year, and $2.8 billion in healthcare costs every year. And these patients come to the hospital frequently and have long lengths of stay. And there's 5 reasons, the top 5 reasons patients get admitted to the hospital includes heart failure. And the other things are giving birth, COPD and bronchitis, a heart attack, and osteoarthritis of the knee. So a very common indication for coming to the hospital. And this was a study in the US that showed what was the projected burden of heart failure. And what you see here is the projected burden, assuming a 10 per 1,000 person years of patients over 65, you'd see here that this was the projection. And you can see here 772,000 cases projected in 2040 in the US. And you can see here what the actual projections, where the actual heart failure cases are, 670,000 in 2007. So we really are having an accelerated growth of heart failure in the community. And if you look at Alberta specifically, 8,000 newly diagnosed heart failure cases every year. Median length of stay in the hospital is 7.5 days, so more than a week. 25% readmission at 30 days, so very high readmission rates, and 6,300 hospital discharges per year for heart failure. And how are we doing in terms of therapy? And I would just point you out a couple of things. If you look at the MRAs, and these are the patients who should have been on an MRA, 60% or more are not on an MRA. If you take ACE, ARBs, or ARNI, you can see here there's a substantial number that are still not on guideline-directed medical therapy. So we're far away from where we need to be, and this is from 2018. And we don't get these, not only do we not get them on therapy, we don't get them to target either. And this is the percent of patients that are actually on target therapy for ACE inhibitors, beta blockers, MRAs, and ARNIs. And you can see here that in 2017, we were doing a very bad job. And you can see here's the trends for mortality and readmissions in both acute MI and heart failure. And although we do see that there are some trends downward, you can see here that the 30-day readmission post-discharge is really only trending slowly down for heart failure, and that the in-hospital mortality is trending down, but the 30-day post-discharge is really pretty flat. So again, we have a lot of work to do, and I'm going to move this on now to Dr. Sharma, who's going to talk to us about the heart failure pathway and early continuity clinic. Dr. Sharma.
Thank you, Sandeep. And just going. Can someone, or can everyone see my screen?
Yes.
Okay, perfect. So I wanted to thank Sandeep for the wonderful introduction. I wanted to thank Novartis for putting this together, and for everyone who joined us on a Thursday evening, and also for my other co-speakers for putting on an excellent talk, which you guys will all get a chance to hear. I get the pleasure of starting with the first leg of the race with the baton, and my goal is within a short 20 minutes, sort of give you the overlay of heart failure and where we've come in the last few years, particularly the use of the heart failure pathway, order sets, and just touching upon the early continuity clinic, because I know that'll get talked on a bit more about as its evolution by Dr. Howlett. And so I have some relation to commercial interest, but nothing that would conflict with what I'm about to present here. And so as you can see, the more you intervene, particularly in medicine, the better the outcome you get. That doesn't mean that is the mantra for everything in life, but with heart failure, the more specific interventions we get involved in, and I'll sort of elaborate. So this will include things from the use of assessment of their LV function, to ambulation, to teaching, to bundle sets, to order sets. You actually see an improvement in risk stratified admission rates, in mortality. And so this is the essence of why I'm interested in looking at the order sets. And to go a step further, you will recognize three of the authors of this article who are also speaking today, but really they were able to show quite eloquently that when you use the order sets, and this is the SCM order set, you actually improve those interventions that I talked about that we should be using. And some of them include, as you can see in the top left corner, the use of daily weights, which is so imperative to our treatment of our patients, discharging on appropriate medication, in this case, beta blockers or ACEs and ARBs and ARNIs to draw that statement out. EF measurements, so getting an echocardiogram, and referral to heart failure clinics, i.e. or specialists, other specialists that treat heart failure patients. And so why is this important? Well, when you use the order set, you actually improve outcomes. And this was also, these are unadjusted odds ratios, and this is from the same article, which is now in CJC Open. And you can see that you improve not only the hospital length of stay, but also 30-day all-cause mortality to some degree. And although the 30-day readmission was sort of equipoise, you can see that if you use a combined endpoint, there does seem to be a trend for utilization of the order set and improved outcomes. So what are these quote unquote order sets I keep talking about in transitional bundles? Well, they include admission order sets. They include transition to community care bundles. They include admission to discharge checklists and discharge management planning. And I think there was one question that I received earlier in the week in regards to how people can help out. Well, you can help out by identifying which patients should be on what order set. And in fact, getting them on these order sets actually stratifies their care from those who do and don't, and actually gets them on the right path to being treated for heart failure in a not only a goal-directed way, but in a manner in which they will be then followed up properly and adhere to the principles of heart failure therapy that we so hammer into our patients. So why is this so imperative? Well, please pay attention to those values circled in red as they are statistically significant. But you can see that the use of the order set and transition bundles, and this is not just related just to transition bundles alone, but that you actually have an improvement in the 7-day inpatient readmission that extends out to 30 days, 90 days, and subsequent follow-up, which I'm going to talk about in the next few slides, with not only your general practitioner, but a specialist. And this could be an internist or a heart failure specialist, i.e. cardiologist and or specialist in the heart function clinic. So this is going to be sort of part 1 of 3 in my 20-minute monologue. But basically, my 5 key messages for this part are that patients with heart failure need an echocardiogram, because that needs to inform therapy. they need to be identified early and started on appropriate medications. So that subgroup with an ejection fraction less than 40%, and Sandeep alluded to how improperly we treat some of our patients, but they need to be identified early and started on what we call evidence-based medical therapy. And we're going to talk about cluster therapy, but conventionally it used to be almost in series. ACE inhibitor ARB to beta blocker to MRA, yada, yada, yada. But we're going to talk about a new strategy in regards to how we treat our patients. Nonetheless, they need to be on these medications. There are newer therapies that need to be prescribed by specialists in this subpopulation, and they have better outcomes when managed not only with primary care physicians and specialists, but particularly when they're combined, when our efforts are combined. So more superheroes equals better outcome. So, and this all will equate to better 7-day patient outcomes, not only in terms of readmission, but it extends out, as you saw, to 30 and 90 days. So how do we evaluate these bundle compliances? I'm going to show you some busy slides in the next sort of 5 minutes. But the understanding here is that by using the bundle sets, we start to improve the interventions. And we already talked about in my first slide that increased interventions reduces overall risk, no matter which way you slice it. So we actually studied the SCM population. We looked at a time series analysis of 3-month chunks. We actually we didn't differentiate the initiation times. There was no exclusion except for if they became palliative. And it was a long enough time frame of almost 2 years, not quite short, almost, 2 years, just short of that. And over 2,600 hospital heart failure admissions. And what you see is a very busy slide, but what I want you to take away from this is that through the slides, I'm going to actually show that the utilization of these particular interventions has grown over time through the zone, and it has fluctuated through the hospitals. And that is one shortcoming that needs to be addressed as a key point across the zone, is how do we get everyone aligned on the same direction and pathway? And just as an example, you could see that the use of heart failure order set had a real positive uptake in both the South Health and Rocky View. And yes, it was significant as opposed to, say, the Foothills or PLC, but there was an overall improvement in the zone. And this will change depending on the intervention used. And you can see that when it comes to heart failure medication, a little bit different scatter plot here in terms of the sort of trend and significance, with heart failure medication being more heavily utilized in those outside of the PLC, but generally positive in the zone. And again, another slide to sort of even add another layer to this, looking at the management of heart failure, looking at both the left ventricular ejection fraction and BNP. And you can see that this starts to give us interesting data in the sense that our heart failure order sets and interventions are being used. They're having an effect on the patients in the zone, and they're having positive outcomes. And through this, we then wanted to say, well, what about the patients themselves? And when you actually, so are we actually making a difference other than the metrics by which we're using to actually show that we're actually improving things? What about the patient themselves? And so this is just another slide showing ambulation. But what I wanted to get to was that we actually ran surveys with patients during these hospital admissions, both at the time of admission through close to before discharge, and then 30 days post-discharge. And what we wanted to evaluate was, do patients report better quality of life estimates through use of the heart failure order set and bundle sets? And what we found was that there was a statistical improvement in what we would qualify as their quality of life measurement. We used a visual analog, and people can sort of judge us for the merits of the use of the analog, but you can actually see a statistical improvement that the use of the order set actually has on people's estimation of their quality of life. And this could be for a number of reasons: improved ambulation, proper identification of underlying disease, use of proper medications, getting them on medications they should have been on in the first place, et cetera, et cetera, et cetera. And this is just a breakdown between all of the sites. And you can see in this case, Rocky View seemed to be utilizing the order set, but I don't think that it has any bearing. Like I showed you in the slides before, every site is good at something. And the goal here is to get everyone sort of on the same trajectory with everything. And so what happens when you look at, and so this is the second question, what happens when you look at patients who are treated on units who are using the order set and those who are not participating? Well, you start to actually see a trend that is a bit disturbing for those who are not on units using appropriate interventions. And you actually see increased 90-day readmission rates, you see increased 30-day readmission rates, and 7-day. So this behooves everyone not only to use the order set, but to actually use all the bundles. And then there's one last piece of this sort of pie that needs to be addressed. And that is, what do you do when the patient is discharged, which is probably one of their most vulnerable times, is when you've titrated their medications, you feel you've done the best, they look pretty good, but it's that fear of that unknown. They go home. Are they going to go home and eat a pizza, or are they going to stop taking their medications? And this is where things start to fall off the back of the sort of cart here. And so the concern was drawn out of the fact that after 7 days, less than half of the patients that are discharged are actually seen by their family doctor or specialist, or or their primary care physician, if you will. And so this is across the site, and it varies to some degree, but the median is about 50%. Whereas in a month's time, there's a much better uptake. So this critical period between 0 to 7 days, and subsequently then between 7 and 30 days, needs to be addressed. And so how it was addressed was the idea of coming up with something called a safety visit. And why a safety visit? Well, we're trying to prevent a readmission or potentially fatal outcome or a morbidity of some kind. And so when patients are discharged, their highest risk of readmission is within that 7 days, particularly if they're not seeing their general practitioner or primary specialist. And it also is a time to make sure that they are following or adhering to the discharge sort of treatment that they were put on. And so if the sense is that they cannot be seen in their family practitioner's office within a week, what can we do? And so this is where we came up with what's called the continuity clinic, or quote unquote safety visit. Now, although this hasn't taken shape physically yet, it is well on its way to becoming a reality in Calgary. And I'm only just going to touch upon it, but I'm going to let Dr. Howlett sort of flesh out and give you more insight, because I'm sure there'll be lots of questions about this continuity clinic. And the way it works is, and you can see I've highlighted it in red, is if you are discharged from hospital and you have a clinic referral and you can be seen within 7 days, well, then continue on that path. However, if you do not have a hospital referral and you cannot get seen by a family doctor within 7 days, well, this is the clinic for you to try to mitigate any potential negative outcome. The same applies even if you did have a hospital or heart function clinic referral, but still could not be seen within 7 days. Again, a perfect place for this clinic for you. And this would be patients we would see who would be referred to us from a multitude of sources, and I'll sort of address that. But the idea would then be from the continuity clinic to then direct them, once stabilized and secure, to either back to the heart function clinic as they were once referred, the emergency department if they need to be seen, or the primary care physician, understanding that 75% or more are seen within the first 30 days. And so I have two last slides here. And so this is sort of the workflow that we anticipate. And so the referrals will come from the emergency department, the hospital ward, and the referrals made based on the triaging pattern that I've just described. They will be reviewed in the safety clinic with protocol-driven sort of goal-directed medical therapy. And there'll be more information about that in the evening to talk about how we sort of will design the cluster therapy. And then a determination is made as to their disposition. And we talked about that not too long ago. So in summary, I think I believe I'm on time. In summary, it is a steady but slow progress of implementing these pathways. It has been over the course of the last several years, and I'm happy to show that there has been progress. There's improved processes seen at all sites. I prefer not to pick on one site or another, depending on the intervention and how successful, because we all have different varying importance of the different interventions. There's improved quality of care and patient-reported outcomes, as I showed you. The improved outcomes are seen where full uptake occurs, and this is between units using the order sets and / bundles and not. Heart failure order set facilitates all interventions. However, we still have some remaining challenges which can be discussed. The variability between the sites, as I alluded to, the early post-discharge gap, which again, we've come up with a potential solution and will be fleshed out over the course of the next few months, and introduction of early heart failure community clinic as a pilot project for the gap. So I want to conclude there, and I am not sure, I'll give it back to Sandeep if questions are at the end or at the end of each section.
Yeah, no, that's great. Thanks. We're on time, and I'm going to take the prerogative of just answering two quick questions, asking you two quick questions that are in the chat, because I think they're quite relevant. One was, who staffs the safety clinic? And then the second was, how do you think this will change the significant number of elderly patients?
So I'll answer the first question. I might have some clarification on the second one, but the first one, I believe the goal is to staff them with a nurse practitioner and or with physician oversight. I could be overstepping that conclusion, but Jonathan there can correct me. But that would be the essence of having, like, essentially creating a heart function clinic that actually can exist outside the conventional heart function clinic, but see these patients quickly and efficiently, because as you could imagine, the referral streams would be much more varied than our usual conventional stream, which is basically from the hospital. So the idea would be to have a nurse practitioner sort of model with physician oversight and possibly some other allied help that would help out with other aspects of their care. And the second question you asked was,
it was just about how the elderly, would that change with elderly patients? Would that help, I guess?
so I think, I mean, first of all, it help with all patients, but particularly elderly seem to be probably the most frail, not just from a disposition point of view in terms of other frailty indexes, but just because of polypharmacy and straightening out the medications they need to be on, making sure they're on appropriate titration, and also improving compliance. So my best guess is that you probably would see improvement among the elderly for those several reasons. But I wouldn't say it's just primarily only because we'd be treating their heart failure. I think we'd be addressing multiple.
Sorry, it's Michael. I'm going to interrupt with speech here. Part of that text was missing. It was, how do you think it is going to change with the significant number of elderly people who have died as a consequence of COVID? So the numbers from the elderly population, I think, are going to go down because they're dead.
It's a good question, Jonathan. I think that's beyond the scope of this particular presentation. So I'm going to take a prerogative of saying that he's not going to answer that question for you fully. But I think he answered the question that was actually quite good. I'm going to just go on to one last question. And just the question was, why would not all of the patients on the pathway get referred to heart function clinic? And what is the benefit of the safety clinic versus the heart function clinic? So I think maybe they didn't, somebody probably didn't fully understand, why wouldn't they just go to a heart function clinic instead?
So the people that would not have a heart function clinic assessment within a month, who were felt to be needing a clinic visit within the month, who still had a referral, would actually go to that clinic. I'm trying to see if I can get to my slide there. So the question they're asking about is this person.
Show your slide.
Yeah, is this person right here. So the continuity clinic would be used, but you could see though that from the continuity clinic, they could still be referred back to the heart function clinic. So this was a stopgap measure to prevent that increased readmission rate for patients, referral or not, who might fall through the gap otherwise. And we've seen this happen many a time. And where a patient gets referred, they're not going to be seen in the next 4 to 6 weeks for whatever reason, and they end up in hospital 2 weeks later. Those are the patients that we're referring to, as opposed to the patient that cannot even get in to see the family doctor, who normally would benefit from some heart failure, quote unquote, reassessment. Those are a different population. But both, I think, would benefit from the continuity clinic. I hope that sort of clears it up by looking at the sort of.
Yeah, thank you. I appreciate that. That's good. Good job, Nakul. We're going to move on now. We have Jonathan. He's going to give us a sneak preview of what he calls the CCS Heart Failure Update 2020. Jonathan.
Thanks very much, Sandeep. Can you see my slides?
Yes.
Okay, very good. Just a couple quickies. Please remember that the Heart Failure Clinic is a longitudinal clinic that follows people over time and sees them again and again. The clinic we're talking about tonight is a one-off, and it's really to be that stopgap. By the way, the PCNs in Calgary have committed to seeing patients within a week of discharge from hospital over the next 2 years. So we're hoping that we won't even need this clinic in 2 years. And the last thing is, this clinic will be run out of the rehab center down at the Repsol Center. Sandeep, you're in charge of that. You know that very well. And we hope to have that up and running by the end of March. So for those of you who are wondering why there's no referral form right now, it's because we're in the process of starting. And of course, like Michael's previous question, we can blame that one on COVID as well. Michael, just for your information, we don't plan on seeing dead patients in our clinic. Tongue in cheek, of course, with that one. All right, thanks for the opportunity to give you a sneak preview. This will be very short and sweet. This is the disclosure slide I've been showing over the past year under the prior administrations. And you'll be pleased to know that since the new election, I've updated the picture that you see on the left, but the relationships have not changed. I'll have a coffee with just about anyone. Between 2017 and 2020, there have been a lot of changes in how we view optimal medical therapy for heart failure and reduced ejection fraction. This is a good illustration of what life was like before any treatment for an outpatient. This is not an inpatient. This is a so-called stable outpatient diagnosed in your office with low ejection fraction heart failure. And you can see that it becomes very apparent that it's really about cancer chemotherapy principles here. We use multiple mechanisms. There's at least 5 different mechanisms of therapy now that reduce mortality. And if we combine them much the same way as we would use R-CHOP or CHOP therapy for a lymphoma, they all do something different. They all work synergistically together, and they all give much better outcomes. And you can see the number needed to treat is something in the range of 4 now compared to the previous. The trouble is we have this old algorithm that was very stepwise. You do one thing, you do the other. We know that median times to titration in Canadian heart failure clinics are about 12 months. That's right, 12 months. And now we have more therapies than we did before. So how can we manage that? That's part of the reason why we're having this tonight. The new guidelines have also taken into account a couple of really important concepts, and you can bring this one to your patients. In Alberta today, as we speak, the most common single combination given to a patient with a heart failure and a low EF is actually an ACE and a beta blocker and a diuretic. So that is the red line that you see on this slide here. We have life tables on the left, we have we have survival curves on the right, and you can see that compared to the most prevalent therapy represented by the red lines, the updated quadruple therapy with an ARNI, beta blocker, MRA, and an SGLT inhibitor, that's the blue line. And whether you're 55 years of age when you start the therapy or 80 years of age when you start the therapy, you can see that differences in overall survival and event-free survival range anywhere from 8 to 2.5 years. So this is a huge, huge benefit over time. The next thing that's really important to recognize is that these benefits occur very quickly. I could show you the same thing for a beta blocker, for an ARNI, and what you see here is a time-dependent variable of the hazard ratio. In the upper right, which is the blue background, you can see that at day 28, the DAPA-HF trial, that was the SGLT trial, became positive. That's when it reached a p-value of 0.04, 0.03 actually. And the only thing that really changed over the next year is that there were a lot more events that accrued, and that became more certain in everyone's mind, so that we had something like 7 zeros in front of it. And that's true for all of the other outcomes as well. So these drugs, they work powerfully, and they work right away. Then we've always had this as an outpatient, and there's always been reluctance to really aggressive in the inpatient. But in the past 3 years, we've also had a couple of really important landmark trials. One of them, an inpatient randomized trial of switching an ACE inhibitor to an ARNI while still in the hospital, and then followed along. And what we found were profound and immediate reductions in BNP on the left. That was the primary endpoint. But we also saw significant and early, within 2 weeks, separation of readmission. This was the first ever drug shown to reduce hospital readmission for acute heart failure, for example. And these curves remained parallel after week 8. At week 8, this is important because at that point, everyone got the sacubitril/valsartan. No one was continued on an ACE after the 8-week mark, and those curves do not come together after a full year. It was true for patients with old heart failure as well as brand new heart failure. And then even more recently, just a few months ago, this was an SGLT inhibitor. This is sotagliflozin. It's not available in Canada, but it does a lot of the same things that the other available SGLT inhibitors do. This was an in-hospital acute heart failure study. This was started within 3 days before discharge versus placebo. And again, within a couple of weeks, you see the curves diverge, and they continue to diverge throughout the time in the trial. And there was a dramatic 25% reduction in the primary endpoint. That's a number needed to treat of only 3 or 4. So that is a very profound, early, sustained, robust improvement in outcomes. And for those of you who are wondering, what about the kidney function when you're starting all these drugs in the hospital? And the answer is, as long as they were stable, relatively stable when you started it, they actually had better renal function at 1 month than they did without the drugs. So these drugs are actually good for your kidneys, not bad for your kidneys. So that leaves us to the 2021 heart failure guidelines update. This will become available on April the 5th. Of this year. It'll be available electronically, and then the print versions will be sent out on April the 8th. So it's under embargo, but I'm presenting here the slides that were shown at the CCC meeting back at the end of October. These were in draft form. I can tell you that I would be surprised if there was a substantial difference between what you're seeing here and the final product. So keep that in mind. What you see here is that now we have 4 lines. We have ARNI or ACE and then ARNI left up to the discretion of the clinician. And then beta blocker, MRA, and SGLT inhibitor. These are foundational or standard therapies. There's 4 of them. I call them the big 4. And that's what most people with low ejection fraction heart failure should be on unless there's a good reason. We have accelerated the time to titration to approximately 3 months. And then we decide whether further treatment is necessary. And there's a bucket of medications that we choose from, some of them ahead of others, depending on the presentation of the patient. So that's where we are now. But what we don't have on that slide comes later. It's devices. Devices have been pushed back a level after all of those big 4 have been optimized. And so you see referral for ICD-CRT. We look at advanced heart failure therapy for people who simply can't tolerate or don't do well on these. And of course, other therapies as appropriate at the bottom. So that's the basic architecture of the new guidelines. It's really the big 4 right here on the top. We consider other therapies depending on their presentation. You see that on this slide, it's coming in from the right side instead of the left side. We hope that they'll be titrated within the 3-month period. With all of this, outside time frame would be 3 to 6 months, and then we reassess them. So no repeat ejection fraction until all of the dust has cleared, and that's primarily for assessment for devices. And then on the banners on the sides, you see the usual treatments that we give all heart failure patients, such as treatment of comorbidities, exercise, and diuretics, etc. So that's what this looks like. However, one thing it doesn't do, you cannot expect a lot of help as to what to do first, second, and third, and that's what the next 2 parts of this talk are all about. It's about how do we get from the top towards the bottom of this guide, and we're going to have to do that ourselves. So we're going to present something to you that perhaps will make some sense for you. There'll be more on this on May 7th, the 8th. This will be our 8th annual heart failure update, which is virtual this year. And it's very well priced. We think it's a great program. We're doing joint sessions with the Heart Failure Society of America, the European Heart Failure Society, and JACC HF. So tune in. I think you'll have a lot of fun with it. So thanks, Sandeep, and I'm back to you.
Yeah, thanks, Jonathan. Great talk, and excited to come to that meeting. There was a question earlier in regards to SGLT2 medications and in non-diabetics with heart failure. And I wonder if you could just elaborate that information, because I think that needs to be very clear to the audience here.
Sorry, the question, what am I elaborating exactly, Sandeep? Sorry.
The use of SGLT2 inhibitors in non-diabetics with heart failure. With systolic heart failure in particular. You could comment on diastolic heart failure or HFpEF if you want as well.
So number 1, the overwhelming evidence for these drugs are in 2 conditions. One is heart failure with reduced ejection fraction. The overwhelming evidence for that, both inpatient and outpatient now, and it doesn't matter if you're diabetic or not. Identical outcomes, identical improvement in clinical condition, whether you have diabetes or not. That's important. There will be coverage issues. I'm sure that'll be asked later on in the questions, but that's key. The other big bucket of patients that do well with SGLTs, chronic kidney disease with proteinuria, that is with the anything over 30 milligrams per millimole, I think is the unit. There's many on the, Jeff, you know the right units better than I do. I know you're listening. And that's the other big bucket of patients that do fantastically well with these drugs. And again, it doesn't matter if you're diabetic or not. So really, those are the two groups of patients, Cindy.
Yes, thanks, Jonathan. And that's important to recognize, that it doesn't matter if you have diabetes. And I think all of us are saying in a chorus that these SGLT2 inhibitors are not diabetic medications. They are cardiorenal medications that happen to lower blood sugar. So just keep that in mind. In the chat, there was a discussion around coverage. How do we persuade AHS and Alberta Blue Cross to get the coverages for these agents, given the information, both SGLT2 inhibitors and ARNIs? Jonathan, do you have any perspective on that?
Well, I've been trying to do that, and I guess whatever I'm doing isn't working. I do know that it's the SGLT question has been put in for heart failure, has been put in front of Alberta Blue Cross for many months now, many months, and probably 6 now. And I know that CADITH just came out at the end of sometime in January, I think, came out with a positive recommendation for in this case, it was dapagliflozin that made the application. So CADITH is on record as endorsing this drug for heart failure, whether or not diabetes is present. So hopefully Alberta Blue Cross will take that cue and will add it to the formulary. It shouldn't take too much because it's already being used for a lot of other patients right now.
Okay, thanks. We're going to move on. And as I told you, we're going to skip the Connect Care heart failure pathway until the end. Just for flow, it works a little better. And we're going to have Dr. Nowell Fine talk about what we've been hearing is coming, or is a very good potential way to manage patients. And he's going to talk about a new cluster medication titration schedule scheme for heart failure, reduced EF. Nowell.
Okay, great. Thank you, Sandeep, and thanks everyone for joining tonight. Yeah, I'm going to talk about this proposed mechanism for improving titration and adherence to recommendations, and it's kind of been built up quite nicely by Jonathan, Sandeep, and Nakul. So these are my disclosures. Yeah, so you've already heard some of this, but we'll briefly touch on some of the challenges and barriers and the importance, of course, of optimizing medical therapy for HFrEF. And then we'll spend most of our time talking about this proposal for this new strategy, which we're going to be testing out, called the cluster scheme. We're not going to get into really any evidence or rationale with regards to specific therapies or therapy classes. We're going to kind of take a big picture approach tonight. Okay, so in the beginning, or in earlier times, we had a smaller number of choices, right? For many years, we didn't have new therapies, and we relied on a beta blocker, ACE inhibitor, an ARB, or an MRA, or sorry, not or, but and, for the treatment of our patients. And for other patients, we would add additional therapies based on need, diuretic, nitrate hydralazine, and or good old digoxin. And then, as you've already seen, in the last several years, it's been really quite amazing, and it's a good problem to have, that we've had incredible development and progress with new therapies, and many of them have already been mentioned. And it's hard to figure out where do we fit each one of these new therapies in respects to the therapies that we already have. It's becoming a very crowded and complex picture. Not to mention, if you add device therapy and some of the other interventional therapies like MitraClip and advanced therapies for heart failure, cardiomems, monitoring techniques, and of course, all the comorbidities that these patients bring with them, it's really a mess. You know, it's very hard to sort out what order to treat these patients in and how best to individualize therapy. And we know, and you've already seen a lot of data about this, that heart failure patients are historically undertreated. And this has always been this way. And this has been proven in clinical trials. It's been proven in registries, and it's been shown in various quality assurance and other assessments of clinical practice just about everywhere. And it's not an indictment of any healthcare providers. Everyone works very hard, but there are a number of factors that conspire against us when we're trying to optimize therapy. And I've just listed a few here. So number one, of course, is that heart failure patients are very complex. You know, I said things were simpler before, but they were never simple, right? That's the last word we would ever use to describe our patients. You've already heard this from Jonathan. There was no clear guidelines on medication titration, right? We have to kind of make this up on our own. Monitoring and surveillance is challenging. It's time consuming, both for us and for our patients. Access and availability may be limited, particularly for new therapies. That's already come up a few times. And that's not even mentioning some of the disparities that exist with regards to treatment, whether it be sex or gender-based, socioeconomic, rural versus urban, and many other disparities that are out there. Patient preferences, what do they want? All of these things and more lead to a certain amount of inertia that can develop when we're trying to up-titrate therapies for patients, and it can take months, and for many of them, they never get there, especially for patients who we consider or they consider themselves to be quote-unquote stable. And so this is now recognized internationally across the heart failure world, and all the major societies are drawing their attention to this. Here's a recent statement released earlier this year from the American College of Cardiology. This is from a working group dedicated to this issue that they've called a heart failure collaboratory. And this statement points out many of these problems and the increasing complexity of managing these patients with all these new therapies, and the need for a framework to manage them better and to follow a cookbook on how to treat them. A couple quotes from this: the development of practice guidelines that address sequencing and optimal dosing has been challenging. You could change challenging with the word absent. And another quote: an implementation framework for drug initiation and titration should be developed to promote more rapid uptake of new therapies. And so this publication, it's coming out next month along with the guidelines in a dedicated issue of the Journal of Cardiology. Our group had an opportunity to really take a hard look at this and address this and come up with some practical solutions that we hope will help with this problem. And so Jonathan's already talked about this, but I will add, before we get into any further into the cluster scheme, at the moment this is a proposal, right? It hasn't been validated yet, and it hasn't been fully tested. That part's coming. But this is the proposal based on what we know about heart failure patients, and we know about our own behavioral strategies when it comes to up-titration of therapies. So, as you already heard, there's two categories of therapies. There's the foundational therapies. These confer a rapid and robust benefit, and they improve survival. They reduce hospitalizations for all patients with HFrEF across the board. They work in an additive fashion. We already saw some evidence for that. And the bottom line is all patients should be on these if they can be. The rest are personalized therapies. These are therapies that apply to specific patients with circumstances. So Jonathan mentioned the big four, right? Here they are again: beta blocker, renin-angiotensin system and neprilysin inhibition, an MRA, an SGLT2 inhibitor, and all the rest fall into the category of personalized therapies. Okay, so now that we have those two large categories, how do we go further? How do we break this down and cluster them? So we have divided them into three separate clusters, and these are based on their mechanism of action. First cluster is an ARNI and an MRA. They're combined because they have a similar mechanism of action, ARNI or an ACE inhibitor or ARB. Next cluster is a beta blocker or a sinus node inhibitor, right? They both reduce heart rate. And the final one is SGLT2 inhibitors and a diuretic. So now that we have these clusters, as I mentioned, based on mechanism of action, where do we go from here? Well, we pick one preferred medication within each of these clusters, so 3, and initiate them simultaneously. Okay, then we up-titrate in a stepwise fashion, prioritizing treatment with the foundational therapy classes first. And then once we've optimized foundational therapy, then we can titrate and add in personalized therapies that may be needed. They may be needed sooner than towards the end, for example, if there's a diuretic. But generally they're a lower priority. Okay, and I'll show you this in graph form in just a moment. Couple principles here, important principles. Maybe the key principle is that time is of the essence, right? You already heard that we take a long time to optimize patients because it's difficult. They suffer events and other problems in that time period. Start early and move quickly. Initiate one medication from each of the 3 clusters and up titrate simultaneously. Okay, so we're used to making one change at a time. This recognizes that that patients can often tolerate, not all, but some can tolerate more than one change at a time, and that they suffer by making one change at a time as drawn out over weeks and months. So this means you can make up to 3 changes per visit. Use a titration schedule that's fast, 1 to 2 weeks between every change. Target optimization of all foundational therapies within 12 weeks, right? Not 12 months, within 12 weeks is really where we want to be optimizing our patients with regards to these 4 therapies, if possible. In-person appointments are not always necessary, right? This has become easier in COVID as we've become more used to virtual care and made better use of it. We don't need to see our patients for every titration change, and that will speed things along. And then key monitoring parameters, I'm sure you're all familiar with those. So this is what this looks like. And it's a lot to take in on first glance. And so I'll walk you through it. And then in the next talk, Dr. Miller is going to walk you through some more practical examples of this so that you start to get a feel for it. So at the top, there are the 3 columns based on the 3 clusters. Again, diuretic, SGLT2 inhibitor, ARNI and MRA, and then the last one, beta blocker and sinus node inhibitor. And then as you go down is each subsequent patient encounter, which is color-coded to help guide you. So the first one is a face-to-face encounter, right? We always need to kind of see our patients first in person when we meet them. Okay, and then we see what to do with each cluster by following the column down. So we start with preferred cluster A medication, okay, which would typically be an SGLT2 inhibitor unless they need a diuretic. Then move on, start cluster B, either an ARNI or an MRA, and then also start cluster C, which would typically be a beta blocker, although you may have contraindications to that. So you do that all at the same visit, okay? 1 to 2 weeks later is your next encounter, coded in blue. This can either be face-to-face or virtual, depending on how things are going. What do? Titrate cluster A, start the second cluster B, because both in this cluster are foundational, and then cluster C, titrate the preferred medication. Another 2 weeks go by. This can be a virtual visit or an in-person visit. Titrate it further, add a diuretic if needed, or maybe reduce a diuretic if not needed. Titrate further, alternating the 2 agents that are foundational therapies in cluster B, and then alternate or further titrate in cluster C. And keep going this way until you optimize foundational therapy and or needed to add personalized therapy within a goal of 12 months. A couple more principles here. So do not initiate medications from the same cluster at the same visit. This is thought to increase the likelihood of intolerance because they have a similar mechanism of action. So in the absence of a preferred choice, uptitrate each one on alternating visits. So you could do that with an ARNI and an MRA, which are in the same cluster. Tolerability will vary. Of course, it always does. Intolerance will happen. It always does. What was been shown and what we understand and is represented in guidelines and many trials is that being on lower doses of all of these foundational therapies is better than being on high doses of a few. There's benefit from even being on a low dose of a foundational therapy. And intolerance, what do you do when you come across it? Well, if it's not due to volume depletion, then you need to halt titration of that drug and focus on other foundational therapies, all right, and optimize them first. And always keep in mind that diuretics are for relieving congestion. If there is no congestion, then you can down titrate diuretics and hopefully discontinue them. Okay, so that's a whirlwind tour through that cluster therapy approach. And so in summary, heart failure advancements have increased dramatically and increased the complexity of this landscape for trying to optimize therapy. There are a number of other challenges in addition to a number of choices that with all the choices that we have that make this difficult. We have proposed a framework for optimizing heart failure therapy that is based on clusters of therapy classes. And of course, further research and experience is needed to determine the efficacy of this approach. Okay, thanks for
Thank you,
hanging
Noel.
out.
That was great. Again, whirlwind, but you did a great job of explaining that. I think there was some clarification in regards to the relative importance of patients achieving their target dose versus getting patients on each class of drug. Can you make a comment about that?
Yeah, sure. So we would certainly prioritize or prefer that patients be on at least low doses of the foundational therapies. Okay, so before you really start maximizing one of those foundational therapies, you want to be sure to introduce all four of them. And that's, that's a very clear part of this scheme, is that patients benefit from being on even low doses of all four.
And Noel, can you comment about, is there any literature in regards to that from the standpoint of outcomes, getting them all on low doses versus titrating to higher doses on one and then moving on to the next?
So the data from that comes from really all of the clinical trials that look at these therapies individually, okay? And this is one of the challenges of this area, is that we don't have data that's based on clinical trials that includes all of these therapies, right? Clinical trials look at one therapy added on to the background of all the other therapies. And what we know from that is that regardless of their background therapy, patients benefit from being on a low dose of those foundational therapies, even if that's all they'll tolerate is a low dose. Okay, I hope that makes sense and it's clear.
That totally makes sense. And just if you could just clarify one other point, and Russell brought this up, Dr. Quinn, in regards to the coverage, that's going to be an immediate issue, and maybe kind of related to that is, can we, how do you do this with the coverage issues that we currently have, given that, it'd be hard to get them on a little bit of all of these drugs because of the way that Blue Cross is. I think, if they have private coverage, that's not an issue and you just do what's right. I think they don't have coverage. How do you manage that part of it?
Yeah, I mean, it's a good question. It's come up already tonight. I think it's going to keep coming up because it is a real hard wall that you come up against. You have to do your best with what you have that's available, okay? And you have to simply, if you don't have access to one type of foundational therapy, such as an ARNI, then you have to, use your best to substitute for what is available, such as an ACE inhibitor. I don't have any magical answers or any other, suggestions. And, I think some of the strategies that have been talked about to try to improve this are important. We need to keep hammering this message home to our government. We need the voices of the patients to be heard, because those get listened to typically louder than ours. And we have to do the best we can in the meantime.
And then if you were to choose between Lasix and an SGLT2 inhibitor for congestion, how would you make that decision?
So an SGLT2 inhibitor is a foundational therapy. So all patients, we want them to be on that because there's a definite mortality benefit. They are not as effective at relieving congestion as a diuretic. And so if a patient, such as Lasix, so if a patient is congested, you need to relieve that congestion. Okay, so otherwise you're going to have difficulties with your other medical therapies. But once that congestion is relieved, hopefully when the other therapies are optimized, there will be little or no need for that diuretic because of their optimization, if that makes sense.
Yeah, thanks. And so just one quick question from Michael. So I think you want to do that verbally, so go ahead and do that. And then a comment from Jonathan afterwards, and then we'll move on to the next presentation.
So yes, Noel, you and I both work in the cardio-oncology clinic, and we see patients in the cardio-oncology clinic whose life expectancy is longer with the multiple very expensive therapies that they are getting in the cardio-oncology clinic are, the drugs in the heart function clinic are, yeah, they're expensive, but they're nowhere near the expense of the agents which are used in oncology at the moment. So how do we persuade the government that, something, we're actually really cheap if you cover these drugs compared to the prices that you're paying for the cancer patients? How do we do?
It's a great point, Michael, and I couldn't have summarized that any better. I think that you probably don't have time to really address it with the justice that it deserves, but I think there's a number of different strategies. Many of them have been tried. A lot of work's been done. I feel we face real challenges. I'll go back to kind of saying that we need our patient voices to be a part of that. Because I think that really has a more significant effect than our voices. We need the data to prove it, and that's part of what this initiative is all about. And we need to persevere, right? We can't take no for an answer. We need to keep coming back,
But
year
I
after
also
year.
think that patients do not realize that their heart failure prognosis is significantly worse than the cancer prognosis. And so they think, oh, I've got a bit of heart failure, nothing to worry about. And yet their prognosis is a darn sight worse than an awful lot of cancers. And until the patients realize it, I don't think their voice is going to be heard because they're not going to make a voice.
Yeah, I mean, I couldn't agree with you more. That particular population, they're often so relieved to get through their cancer therapy that they don't realize what's staring them in the face with their heart disease. We need to get the message across to our patients, and we need to find the ones that will be willing to lend their voice and deliver that as effectively as we can.
Jonathan, you had a comment?
Yeah, quickly, thanks, Noel. I can, if you like, I can lend you my Grim Reaper costume when you do your next heart failure clinic, Noel. It works quite well. In all seriousness, look in the chat. Kristen just made a comment. I agree with it. There's lots of little tricks that you can use. Number one, filling out the forms. Internal medicine and all of its subspecialties, including cardiology, have the ability to prescribe the sinus node inhibitors and ARNIs, and use it well, use it frequently. I can tell you that I never ever lie when I fill out any of those forms, but I do make a lot of mistakes that tend to favor coverage of patients. Make the life of your local rep, your SGLT rep or your ARNI rep, make it miserable. I'm calling on all of you to make it miserable, and to do that by getting an access to the ARNI for, so Entresto, sacubitril, valsartan. If you ask them, they'll give you a month's supply or whatever you need in order to tide them over before the coverage kicks in. And similarly, you can get samples either through filling out forms for the dapagliflozin and empagliflozin, and with canagliflozin, there's a phone number to call. So if you spend some time, you can get around a lot of these access issues, but it does take effort. And it's one of the reasons why disease management and the early safety clinic are, we hope, going to be successful. Thanks for letting me say that, Sandy.
That's great. It's a good point. And there was another question in regards to SGLT2 inhibitors. I don't know if Jonathan, you want to answer this one. And the question was around, do SGLT2 inhibitors cause euglycemic acidosis in patients who have heart failure, I guess without diabetes, presumably, because we know that it does happen in patients who have diabetes, but in the non-diabetes patients, does it cause euglycemic acidosis?
Yeah, good point. So number one, these drugs, it's really the volume depleting / traumas that euglycemic ketos that are caused by these drugs. In this, it's really important to recognize that if you were in these studies with SGLT inhibitors, whether you were diabetic or not, whether you were on insulin or not, if you were on study drugs, so it could be placebo or the SGLT, and you got admitted with an acute MI or acute heart failure, they were instructed to continue the study drug. And in 98+% of cases, that's exactly what happened. And as a result, there were like 4 out of over 2,000 patient years of actual exposure in the DAPA-HF trial. There were, I think, there were 3 DKAs. One of them related to an acute MI and the other 2 related to trauma or surgery, not volume overload, and none of them were related to an acute heart failure exacerbation. So if it's not volume depleting or traumatic, do not stop the medication. That's been my practice. So that's really, really important. By the way, no patient without diabetes has, in any of the randomized trials, has gotten DKA from these drugs. So it's really a diabetic specific problem, that one. That's a great question. Glad I didn't have a slide for it because of time issues.
Yeah, that's a great question. And Kristen also mentions that she switches the patients to Entresto immediately post-hospitalization. So the next visit, I guess, after hospitalization, because she's got them on all of the other foundation therapies that she can get them on given coverage, and then makes that switch afterwards when she sees them in follow-up. So you have to just get your ducks in a row so you can get the coverage. So if you're thinking about coverage, you know you want to go to Entresto, just make sure that you got yourself set up correctly and on all of the right medications, which is the point, where Noel's like, get them on a little bit of everything. That will make it so that when you fill out the form, you can say, yes, they're on this, they're on this, they're on this. And that allows you then to have coverage with Entresto. So another sort of, besides the clinical reasons, there's the practical reasons of getting coverage helps when you get them on a little bit of all the drugs. So I'm just adding that component in myself. So we're going to move on to Rob. Rob's going to take us through that cluster medication process with a patient in mind. So making it very practical for us, and keep on with the questions and we'll keep on answering them as we go.
Thanks for the introduction, Sandeep. Thanks to Novartis for organizing this, and big thanks to Jonathan and Nowell for really setting me up for success here. So hopefully you've been convinced that we need to think about initiating titrating medications in a different way. And hopefully Nowell's convinced you that our way is not the craziest way to think about it. So really we wanted to go through a case, just because, like all good central figures, there's a lot of information in this figure, and we thought it would be nice to just go through it piecemeal with a case, because that's the best way to go through everything in medicine. So this is a real case. So 52-year-old gentleman who saw his family physician for new onset dyspnea and peripheral edema over a 2-week period. He had a past medical history of diabetes type 2, hypertension, dyslipidemia, OSA on CPAP. He was diet-controlled diabetes, but he was on perindopril 4 milligrams PO daily. And his family physician, who had the credit, sent him for an echocardiogram and then referred him to cardiology after he got the result. So hopefully this is going to run nicely on this Zoom that's full of everybody. So I think everybody in this chat that I looked is familiar with echocardiogram. So most importantly, severe LV dysfunction, but also pretty significant RV dysfunction, sort of in a mild to moderate range, but definitely severe LV dysfunction. The ejection fraction was less than 15%. So in clinic, he was complaining of dyspnea with less than a flight of stairs. I called him NYHA class 3. In terms of his exam, there's a couple important things to clue in on. First, blood pressure was 110 on 76. And this is always a nice gift when you see these people in heart failure clinic, because you know that they have some blood pressure to work with. But the other thing was heart rate was 88, his weight was 82 kilograms. So he was like an average sized person. Lots of peripheral edema. JVP was at 8 centimeters above the sternal angle, normal S1, S2. He had a systolic murmur that sounded like MR. And he had an S3. He had a few crackles at the bases bilaterally, but otherwise warm and not looking like somebody who needed to be admitted directly to the hospital. We had some blood work, which included a sodium of 131, potassium of 4.8, creatinine was 90. This is like the second gift in heart failure clinic. When you see somebody who has good kidneys and good blood pressure, you know you're sort of working with somebody that is going to be able to tolerate a lot of medications. And then hemoglobin A1C was 8.2. So again, the thing about this person to clue in on is they don't appear frail. So you look at them, you're not overly concerned that he's not going to be able to tolerate medications. He has blood pressure to work with, and he has good kidney function. So I think that's one of the biggest critiques, or outside of the ability to fund this cluster scheme, is you have to really pick patients who you think are robust and non-frail. So the way I like to think about going through this is actually just separate out into the clusters and think about each cluster one at a time. We did suggest different parameters that you could use to decide about whether or not you should be adjusting each of the clusters. So for the diuretic and SGLT2 inhibitor cluster, we suggested that the things to think about would be blood pressure. So ideally a systolic blood pressure is greater than 90. And then a GFR greater than 30 would be the things to think about for the diuretic SGLT2 inhibitor. So like Nowell was mentioning, deciding between the two, it sort of depends on how much decongestion you need to do. And he was relatively volume overloaded and very dyspneic. So I actually decided to put him on Lasix 40 milligrams PO daily, and then gave him instructions to titrate his dose if he wasn't losing weight. And just told him that every 4 days, if your weight's not increasing, then increase your Lasix dose, but also call us to let us know. In terms of the second cluster, the ARNI and MRA cluster, so again, the things to think about here are the blood pressure. So systolic blood pressure greater than 90, GFR, ideally you would want greater than 30, and then potassium levels. If you have somebody with the potassium less than 5.2, it's probable that they'll be able to tolerate ARNI or MRA. So he was on perindopril. So even though we say do everything all at once, what we actually mean is think about everything all at once while they're in front of you. So I told him to stop his perindopril, to start sacubitril valsartan 2 days later once he was out of the washout period. And because he had good blood pressure on perindopril 4, I felt comfortable starting him on the 49/51 milligram dose. And then in this last cluster here, beta blockers and sinus node inhibitors, again, you want to think about blood pressure. So systolic blood pressure is greater than 90. And you want to think about the heart rate. So heart rate over 60, his heart rate was 88. So I just started him on carvedilol 6.25 BID. This is a second barrier that's more COVID related and will hopefully be less of a barrier in the future, but getting weekly lab work right now is problematic at best. But he was luckily enough in a smaller community where he's able to get labs relatively easily. So I asked him to do weekly lab work and then plan to do a phone visit in 2 weeks. So again, the way to sort of go through this is just by piecemeal, each cluster one at a time, and think about what can you do in each cluster. You don't necessarily have to make 3 cluster changes each visit, but you should at least think about it. So I did phone follow up with him at 2 weeks. He said his weight was down about 8 pounds. He was feeling better from a shortness of breath perspective. No orthopnea, wasn't having any presyncope. Home blood pressures were 100s on 60s, heart rates were 70s to 80s. And in terms of his lab work, it was looking pretty good and essentially stable compared to when I first met him. So sodium was up to 135 after some diuresis, potassium down to 3.6, creatinine was 86. And blood sugars at home were sort of in a 7 to 9 range, which correlates with that A1C that's elevated. So now we're down to this blue tab here where we're doing phone follow-up. So again, we thought about cluster A first. And because his congestion was improved, I told him to change his Lasix just to as needed for weight gain. And we arranged to start him on empagliflozin at 10 milligrams PO daily. For the second cluster, again, his blood pressures were good. He wasn't having any presyncope. His potassium was, if anything, on the low side, and his GFR was certainly over 30. So we started him on spironolactone 25 daily. And then he was tolerating all of his drugs well. Blood pressure was good. Heart rate was good. So we increased his carb 12.5 BID. He was doing well overall. His kidneys were holding up. So I told him to do lab work in 2 weeks and then arrange for more follow-up. So the clinic follow-up at 4 weeks, his shortness of breath was again improving. He said he could do 2 flights of stairs before he needed to stop. He wasn't having any orthopnea, no edema. He was having occasional pre-syncope. And the one thing that came out when I talked to him is he didn't realize he was supposed to just take the Lasix as needed, and he had just continued it. So blood pressure now was 98 on 56, heart rate was 68. Really, all his leg edema was essentially gone, but his JVP was at the sternal angle. Chest was clear, no S3. And then what we saw was he had a little bit of an AKI with his creatinine going from 88 to 110. Sodium was 135 and potassium 3.9. At the same time, we'd arranged to get a coronary angiogram just because this was a guy with diabetes, hypertension, dyslipidemia, and his coronaries had looked good. So now we're here at the third visit. So in the first cluster, we just reinforced that really he was supposed to stop taking the Lasix. And I was pretty comfortable based on the exam that a lot of his renal dysfunction was based off of the diuresis. I decided not to change anything in that cluster. I just wanted to give him a chance to gain a little bit of fluid back. So I didn't want to increase his empagliflozin. In terms of cluster B, his blood pressures were a little bit lower, but he wasn't having any unmanageable pre-syncope, and his systolic blood pressure was still greater than 95. So we increased his Entresto to his sacubitril valsartan up to the 97/103 dose. And then we also told him if he was feeling good in a few days to increase his carvedilol up to the max dose at 25 BID. Again, we told him to get some blood work in 2 weeks. And we just did a phone follow-up after that. So at that point in time, he was still having some shortness of breath, but overall was stable. His pre-syncope had improved after stopping his Lasix. Blood pressures at home were running in 90 to 100 on 50 to 60 range, which is certainly within a range that we see quite frequently in heart function clinic and people tolerate quite well. Heart rates were mostly in the 60s and occasionally up into the low 70s. Sodium was good at 137, potassium 4.2, creatinine 85. So at this point in time, in terms of each of the clusters, he was getting close to being on full dose of all of his foundational therapies. So in terms of cluster A, the only thing that wasn't at goal dose was his empagliflozin. Again, his kidney function was good. I didn't say this, but his sugar control was reasonable at home, but maybe still a little bit on the high side. And he was no longer in this volume deplete state. So we arranged to increase his empagliflozin to 25 milligrams PO daily. In terms of cluster B, we thought about it, but his sacubitril valsartan was already at goal. His spironolactone was at goal. So really, we just congratulated ourselves that he was at goal for cluster B. And for cluster C, we had increased his carvedilol the previous clinic visit. His heart rates were pretty consistently less than 70. So we elected not to start ivabradine. At this point in time, would be essentially titrated up to goal dose on foundational therapies. So we had arranged to do lab work every 4 weeks. And then made arrangements so he could contact us if he was having any difficulties, and went on to arrange a clinic visit in 3 months after an echocardiogram. So in terms of symptoms, he was essentially unchanged when we saw him at that 3-month visit. Orthopnea, P&D, leg edema were all resolved. No significant pre-syncope, still running low-ish blood pressures, but again, very reasonable within a heart failure clinic to see patients with blood pressures of 90s on 60s. And this was his repeat echo that was 3 months after optimization. So he was in sinus rhythm, still had severe LV dysfunction with ejection fraction of 30 to 35%, but improved from before. His right ventricular size and function had improved, and it was probably just that he was too congested during the first echocardiogram, and his RV was a little bit blown out. And the other thing was that he did have some mitral regurgitation on the first echo, which had already improved by the repeat echo. So again, the big thing about the case is that he's not a frail guy when you see him in clinic. And it's not uncommon that we see people that we look at them and we say, they really don't pass the frailty test, either by objective parameters like systolic blood pressures, renal function, age, or just subjective factors like the eyeball test. So this is not part of the document that we put out together, but it is what sort of percolates in my mind when I see somebody who's frail. For instance, when I see them in cardio-oncology clinic, I really am not convinced they'll be able to tolerate more than one medication at a time. The other thing is I'm not convinced they'll be able to tolerate any of the medications. So I want to introduce them one at a time to figure out which drug is causing which symptom, or if it's related to their chemotherapy and unrelated to what I'm doing. So this is a proposed algorithm that, again, just sits in my head where I make one drug change every week, slowly increase each of the drugs, but try to separate them out enough that I can figure out which drug is causing which side effect or symptom. And similar to what we've proposed with the cluster effect, if you run into an intolerance in one category, you just switch to titrating different agents and sort of adjust this as you go. This is a lot more work because it adds a lot more titrations for the patients, as well as a lot more phone follow-up. But again, I think it's something to consider for people that appear frail. So I think I've used up all my time. If you have any questions, feel free to email me. And then Sandeep, if
Yeah,
I really did not do a good job of picking out the questions from the chat. So
yeah, I can get some questions for you here. So one of the questions was, are the CFC nurses going to start changing their titration protocols according to this cluster approach? So that was one of the questions. What are your comments on that? Do you think that it's ready for prime time in heart function clinics or for just specific individuals at this point?
So I think it all depends on the attending physician in the CFC as well and their comfort with this, because we don't want to force this on anybody. But what I'd say is I think it is ready for prime time as long as patients are passing this frailty test. I don't think it can be applied indiscriminately across the cardiac function clinic. I think you really have to think upfront. Do they have blood pressure to work with? Do they have kidneys that are going to tolerate this? Do they have other patient factors that I think would make them less likely to tolerate medications? Because I think there's a good proportion of our patients who would not tolerate this. The one thing I would say is we see patients in hospital, and hospitalized patients with heart failure are quite a bit more frail. And if you look at the number of changes that I make across a week on heart failure service, it's at least one change a day for each patient. So it's actually 7 changes in a week. So if you think about an outpatient group who are inherently less frail than an inpatient heart failure group, I think there's a good chance that they'll tolerate 3 drug changes in 2 weeks.
And can you comment on, so the question was around interstitial coverage. You have to have them on MRAs for a month. So how do you deal with that for the cluster approach?
So just like Jonathan said, you really need to make friends and really push different company representatives to try to get coverage for these patients. There's different ways to get samples, either to tide people over while coverage comes through, or to get patient support. And certainly it's an issue for sacubitril, valsartan, or ARNI. It's an issue for SGLT2. It's an issue for ivabradine. And it's not going to be an issue that's going to disappear anytime in the near future, as far as I can tell.
Yeah, thanks. And so just to, maybe I'll push this one over to Jonathan in regards to the SGLT2s and dosage. So Rob, you did increase the EMPA to 25, and the question was that the right thing? Were you doing it just for glycemic control? But then I think I just sort of corroborized that with the DAPA-HF trial and its dosage relative to the low versus high dose. And maybe you could just clarify that as well, Jonathan.
Yeah, thanks, Andy. So 10 milligrams DAPA is the target for either CKD or heart failure. Ditto for empagliflozin, 10 milligrams for either. You can use higher doses of EMPA if you want to use blood sugar control. And I think that's probably why Rob did it in this case, because the sugars were still a bit high and he wasn't on insulin. So you didn't really have to worry about hypoglycemia. These drugs don't do that without insulin or sulfonylurea on board. And then if you use canagliflozin for its indicated purpose, which is CKD, it would be 100.
Right, and just to clarify, the DAPA at 10, you have 5 and 10, right? As opposed to
Yeah,
which you have 10 and 25. So
just so you know, in the conduct of the study is that in DAPA, both DAPA trials, the investigators had the option of starting at 5 or 10. Well over 90% of the time they started at 10. About 10% of the time at some point in the trial, it was cut to 5, sometimes for a creatinine change or a volume change or some other reason. Most of the time it was put back to the 10. So really well over 90% of the patients in fact, we were going to look at dose response in the trial, but realized we couldn't because there were never enough people that had enough exposure to the 5 milligram dose.
right, okay, that's great. Thanks, Jonathan. That's an important clarification from the standpoint of how we dose these agents, because again, some things we're doing for blood sugar and some things we're doing for the heart failure management, and you just got to know what you're doing what for. So just understanding that is helpful.
Right.
Jonathan, you and I are up for this discussion around the care path, and what I'll do is I'll do that, and then maybe we'll come back to some additional questions that might kind of show up. Have a few other ones that were given to me beforehand, but I'll present my slides, and Jonathan, you can jump in anytime.
Well, you're my boss, so I don't think I'll do that.
Just hang on a second here, and I just gonna switch slides. Okay, so I think you're seeing the presentation slides, correct?
We're good.
Yeah, okay, awesome. So from the standpoint of care path in Connect Care, I mean, the background is obviously we're all moving towards Connect Care, which everybody knows that EMR is epic for all of the hospitals. Early on, one of the associate CMIOs, Aaron Lowe, and myself, as the co-chair of cardiac sciences, decided that we wanted to do care paths. We thought heart failure was the right thing to do. Luckily, Aaron was able to convince the higher ups to say we should do this. And Jonathan has been leading the group in developing these care paths. And a care path is, as you know, as you've heard, heart failure is a complicated entity to treat. And care path is a way for us to improve patient care through a more automated process. Again, assistance, not changing everything that you do and not taking over, but rather helping you do what you do naturally and reminding you of things that you want to do. And you heard from Nakul that at the end of the day, when we use the things that are available in the EMR, that we actually have better outcomes. So a care path is just a way to help us use those tools that are in the system inherently. And so the idea is these patients come in with a diagnosis of heart failure. And then when you enter that diagnosis of heart failure within the electronic medical record system, you now have a trigger to put a patient on this care path. And the care path is to help you manage the patient and get them back to their home, back to their family practice home, and outside the hospital. You want to get them from the beginning to the end. So it's supposed to take care of that entire path from home back to home. And when they come in, you have to know their ejection fraction to determine if they're a HFpEF or HFrEF patient. Once you determine that, you can actually move them along the path. And although this looks like a very simplified diagram, and I'm just going to go down the HFrEF pathway, they have a low EF, less than 40, they would move down to the HFrEF pathway. And you can see here, this looks like one little small box, but it has a lot of background processes that occur that help make decisions for you. They don't tell you what to do, but they give you information and suggestions of what to do to allow you then to take care of the patient according to the guidelines that are out there. So, and then it can move you along to, if you've improved or not improved, what exactly you need to do next. And, you know, obviously these kind of care paths are not to completely take over care, but rather help you determine what needs to be done next. So if the patient does not have reduced EF, it moves on to a not reduced EF pathway. And then we decide, hey, if they get an echocardiogram, you find out they're actually HFrEF, they'd move down to this other pathway, and there would be recommendations provided to you. And then again, they can move all the way, all the information in these BPAs or best practice advisories can help you then get the patient to discharge in a safe way. And to just sort of give you an idea, you get this little path, and it can tell you where you are on the path. So you actually see this when you're taking care of the patient. If you've put the patient on the care path, you can actually see where they sit on the care path. It can help you order the things that are important for that patient. So you have all the guideline directed medical therapy available to you. So you don't need to necessarily go to an order set, because it's sitting right here, all the orders that would help you take care of this patient sit right on the care path and assist you. And it helps you with documentation. What is their ejection fraction? Are they having shortness of breath, et cetera? So it helps you with the documentation. And along with that, provides you with recommendations as to how to manage this patient. So again, here are some of the things that you can do for the patient, whether it's a diuretic, whether it's a beta blocker, an ACE inhibitor, spironolactone, SGLT2 inhibitor, hydralazine nitrates, digoxin. There's recommendations that sit beside these things that you can consider doing. And things are sort of grouped according to which are more important and what's less important. And what's really nice about this is that a lot of the information that you need to help make your decision, and this is not the full screenshot, sits right beside where you're looking and deciding what to do next. So I'm not going to be able to show you the rest of this, but there's more information that's then provided to you. Things like what's their target heart rate, what's their blood pressure, what's their heart rate, what's their creatinine, right along with the recommendations, so that then you can make a better decision for that patient and move them along the care path. And they'll even have some warnings for you. So you can see here, if they have a low heart rate, there'll be a little bit of a warning here saying, well, you could advance the beta blocker, but this person has a low heart rate. You may not want to advance the beta blocker at this point, given the heart rate. And the heart rate will be listed below. You can see this over on the other side over here. There's a heart rates and blood pressures and kidney function, all sitting very close to where you're making decisions. Jonathan, do you want to add anything to what I've added there?
No, I mean, it's a lot of information. And for those people on who, I think there's a lot of Southern Alberta people here who are not familiar with Connect Care. So I think the main issue is to see that there's a patient flow. There's a daily algorithm that is working in the background that is meant to help people identify when patients are improving or not improving, and that can affect, that can help them get into the right frame of mind when they're in the chart and looking to make changes. And then there's easily accessed links for the typical types of diuretic doses that you might want to use if the patient's getting better or not getting better. Those are based on diuretic dosing charts used in clinical trials that really I would suggest that they're extraordinarily good dosage charts and that I try to follow myself. So those are my main comments. I really like the way that it's laid out, and if you go through it, you'd see it much more easily than when it's demonstrated, as a screenshot.
Yeah, thanks, Jonathan. So I'm going to get our panel all to make sure that they're visible. I think Nakul can't, but everybody else can just get visible. And I've got a couple other questions. One of them was in regards to just Connect Care and it's not being, everything's being pushed out. And how does that affect the ability to kind of use some of these care paths? And I think, the electronic medical record system is really there to help guide you, but you can see here, there's a lot of other guidance that you can use, whether it's the cluster approach, the 2020 guidelines, the 2021 guidelines, all of these things. So I think, again, we can't completely rely on electronic medical record. It's there to assist you, but the data is all there, the guidance is there, and I think you can still start doing those things that are required to reduce patients' risk. I'm just going to look over here and see if there's some other questions. There was a question for Rob in regards to effective chemo drugs and radiation. So is there any long-term effects of chemo drugs / radiation to the heart's function? So I think, Rob, you could probably answer that one pretty easily, and I'll try to find some other questions that are relevant.
I mean, the short answer is yes, there's lots of short and long-term effects that we see. A lot of our business in cardio-oncology is anthracycline-related cardiomyopathies as well as Herceptin-related cardiomyopathies. So it's not uncommon for us to see people with cardiomyopathy related to that. And then radiation has a long series of potential impacts on the heart, including early coronary artery disease, restrictive cardiomyopathy, dilated cardiomyopathies, pericarditis, long list.
Great, thanks, Rob. I'm wondering whether or not we can ask, I don't see Nakul, but I think he's on here still somewhere, whether or not he would comment on cardiorenal syndrome. I think he recently did a talk for maybe the nurse practitioners, and maybe he could just comment about, how do we handle the cardiorenal syndrome patient, that comes into the hospital, their kidney function's gone off a bit, and you're trying to sort of really you're struggling with the titration of their diuretics, because every time you give them a diuretic, they become, their kidney function gets worse. Every time you stop, they get more heart failure. So how do you manage those patients?
I guess first recognizing that they have cardiorenal and what the actual precipitant is. So if it's low output or venous congestion, or if it's related to primary renal disease. So we have a short amount of time, but there are different classifications for cardiorenal syndrome, sort of 1 through 5. But my goal usually is to try to tackle the venous congestion first. So sometimes even doubling the Lasix or adding another diuretic or amplifying the diuretic effect to try to improve diuresis, acknowledging that the kidney function or creatinine may look like it's getting worse, with the idea that hopefully once you get to a point where you can decongest them and you sort of change them on the starting curve, that you'll get increased perfusion to the kidney and more diuresis. So I've used everything from adding metolazone to adding others, changing the loop diuretic, to even adding acetazolamide when the bicarb goes up in spite of continued diuresis. I did want to bring up a question that I got a direct message for the panel, actually, and that was from Dr. Grinman, and I thought it was it was an important question, not just for me, but maybe the group in general. Was I'm sure everyone has heard of the complex care hub, and one of the questions posed, and I'll sort of repackage it and pose it back to the panelists, is could there be a role for the complex care hub with our continuity clinic? And if so, has that been thought of? If not, maybe we leave it for another day, but I thought that was a very interesting point to bring up. Sorry, I think it was a direct message to me that I just saw as you were going through some other questions. So
Right, from Michelle Grimman. Yeah, so
yeah.
Jonathan, do you want to, I don't know if Jonathan might be the right person to ask on that question.
I think that sounds like something we should look into. So without having an intimate understanding of exactly what the flow processes are with the complex care hub, I don't want to make myself look stupider than I normally look. So instead, I would probably take that conversation offline, but it's certainly worth pursuing. If there's one thing that we don't have too much of in Calgary or anywhere else, it's heart failure services. So I would definitely like to look into that. I just wanted to say a couple things about cardiorenal, just that might be of some help. We've got some internal medicine people on the call. You guys are used to this, see a lot of it. I've noticed, and I think I'm pretty sure Nakul, you and others on our group see this a lot. Our average creatinine is about 250 on our service. And they slow diuresis. Patience is really important. Rapid diuresis can actually make CKD worse acutely. So slow, steady. Furosemide infusions are a good option in that setting. They work well. If they have a heavy component of right-sided heart failure, if you can get fluid off of them in any way, shape, or form, their kidney function will sometimes actually improve because of that. We've seen numerous examples of it. And the combination diuretic that Nakul already mentioned is a really cool trick. So I just want to add those comments to it.
Yes, thanks, Jonathan. I'd heard about paracentesis as being a way sometimes if patients have a lot of fluid in their abdomen, that can sometimes help as well. And then I've had a few times success with SGLT2 inhibitors where their kidney function actually didn't get worse, but they got more tissue edema reduced. And we know that SGLT2 inhibitors preferentially take away tissue edema versus intravascular volume. That was a study by Subodh Verma that showed that. And so I think it's really kind of great that we have that information, and it might be another additive thing along with all the things that Nakul said.
I've noticed that myself, by the way. Agreed.
Yeah, I was going to say, actually, Jonathan and I, in desperation, used an SGLT2 inhibitor to diurese someone who was actually in cardiogenic shock, and it worked. I wouldn't try that all the time, but I was going to say it is probably another tool you can use to try to correct the imbalance, I guess, between the heart and the kidney.
And it also seems to be useful, at least in my hands, for getting patients out of that stubborn diuretic resistance. I do note that Leish said that the nurses can be a key allies for patient education for these patients. And how would you suggest cardiac nurses help with implementation education for these changes and medications? And I think that would be a good one for Nakul.
I mean, our nurses are very involved as it is, but I guess I'm biased because it's usually on one of our cardiac units. But I think continued education of some of the information within sort of the bundles that we have, as well as trying to identify patients, early on that would benefit from these goal-directed medical therapies and getting them on the path. Quite often, people are admitted overnight, and in the early days, Jonathan and I and yourself fought very feverishly to get people to use the order set, banging our head on the wall. It seems to have worked to some degree, but as you know, at the Rocky View, the hospitals had their own order set, and frequently they missed certain aspects of the therapy we normally use. And so I think that's where the nurse could come in as sort of liaison of the, why don't you try this, or this is the order set, or etc. So I think they play a very vital role, sort of as a person who's good for checks and balances, but also as sort of the person who fills in the gaps that we don't necessarily address with the patient. So, like, I will admit, I frequently, or I'll forget to tell patients about weighing themselves or making sure they watch their sodium intake, just assuming they know that. But our nurses are very quick to come back and circle back and make sure that complete education is there. That's the way I see them. I see them as a very valuable part. In fact, it's a nurse-driven clinic, just physician maybe oversight.
That's great. I think Michael has a comment he wants to make verbally.
Yes, so I just want to emphasize something Jonathan said, in that sometimes you need to go very slowly. We're living in a world at the moment where there is this persistent drive to get people out of hospital quickly. And something that doesn't work with heart failure patients? They come in, you try and diurese them quickly, and you just wreck their kidneys, and then you're stuck. And I think it's very, very important to realize that this population, sometimes slow is going to save you so much time in the long term.
Yeah, no, I agree with that entirely. That there was another comment that you made. I don't know if Noel, you want to comment on this. Is that, remember, the best ways to improve outcomes is to ensure patients take their medications.
Oh,
that
yeah.
Early rehospitalization in many cases is non-compliance. So yes. I don't know, do you want to make any comments about that?
I think that's just, we always think that when we send people out of hospital, they take their medications. And, my bet is that 20 to 30% of the times they don't. And they come back in because of non-compliance. And I think it's because, if you told them you've got cancer, if you don't take these drugs, you're going to die. But we don't tell them they've got heart failure. We're very bad at actually saying, you've got heart failure, and if you don't take these drugs, you're going to die. And then maybe we'd get better compliance.
Noel, do you want to comment about whether or not we should be telling patients they've got a disease as bad as cancer? How do you think that works for your patients? Just, I know that Michael's trying to be provocative on purpose, but I really do think we need to know how we should be speaking to our patients in a way that's meaningful to them. Do you have any tips on that?
Well, I think I think, it's the point I was going to make is building the therapeutic alliance with the patient as the key to establishing compliance. And I think, the way you deliver your message is whatever works for you. But it's establishing that that trust and that, the relationship with them as they're part of the team. Okay, and I actually bring it back to Alicia's point about the role of nurses with that. Often they have a very tight relationship with the patient, and they're the ones who are in communication the most. I think non-compliance is often about misunderstanding or a patient not feeling like they're being heard. And we prescribe kind of a list of things for them to do, but we don't kind of hear what they're telling us back. So yeah, I think the message itself can be tailored, and whatever works, I think, goes for you. But more important is that the patient truly understands that A, the severity of the disease, but B, that we're in this for the long haul together as a team.
But I do think we're bad at telling them their prognosis compared to other things. I think cancer docs, the moment you tell a patient they've got cancer, their ears perk up and then they become very receptive. And I think we are very bad at letting people know that the condition they have actually has a terrible prognosis if they don't manage it appropriately. And I'm as bad as everybody else with this. And I've been reflecting on it recently that perhaps the way I can improve my outcomes is by perhaps being a little more blunt or putting it into a better perspective with other conditions.
Yeah, and one comment I would make is we moved away from the word heart failure clinics to heart function clinics because of we didn't want to make the patients upset that they were in a heart failure clinic. But maybe that was a wrong thing to do. If we need to make sure that they understand that it's a serious condition, how can we do that when we call it a clinic that is saying it's heart function, not heart failure? You have heart failure. And that should sound bad because it is bad. But again, I leave it with the heart failure experts to tell us whether or not that's the right or wrong thing. Nowell, I do have another question for you. And as the clinical director of Libin, I'm just wondering if you can comment. There were two questions in regards to rural access to heart failure care, and particularly, this type of cluster medication management. Can you comment on, particularly, I guess, for Southern Alberta, where Libin would potentially have its arms in reach and help? What do you think should be done to try to help improve that, both the care, access, treatment of those types of patients?
Yeah, thanks, Sandeep. And I'm just looking in the chat here. I'm remiss that I did not mention our pharmacists as key members of our team here, and that is my bad. So I apologize. They are critical members of the team, and they play a very important role. So thank you for reminding me of that, and all of us of that. Yeah, with regards to your question, I think there's key resource limitations here, right? That are at play. In a perfect world, we would have heart function clinics dotted across the province, right? The heart function clinics are proven approaches to optimizing, outcomes for patients, and the more of them we have, the better. In the absence, we need to make do with the resources that we do have available. I believe heart failure, treating a heart failure patient, obviously it takes a village. It's more than kind of a doc kind of showing up and prescribing some therapies and saying I'll see you next month or I'll see you in 2 months. It really is a team approach, and if we can develop that, that's great. I mean, I might actually ask for comment from Michael and Nakul and Jonathan, who kind of attend some other heart failure clinics across our province in Medicine Hat, to see if they have any other further comments.
So maybe I can make a comment with regards to Medicine Hat. I mean, the way it runs down there is spectacular. The nurses do a spectacular job. The pharmacy is involved. One of the things that they have done down in Medicine Hat is that they've had a path to care, which is independent of the physicians on the ward. So that if somebody comes in with heart failure, they get referred to the heart function clinic. It's overwhelmed the system. And that's the problem I think that we're going to run into up here is, the comments about how we do things up here is, if you have the path to care in place, it's just going to overwhelm us because there's not going to be enough resources in place to deal with it.
Thank you, Michael. We're coming to the end here, and believe it or not, over 100 participants are still online, which is great. I would just like to make a comment on one of the comments that are in the chat, and it was made me laugh. It was Jackie who said that maybe we should, instead of using BFF, use HFF, so heart failure forever, instead of best friend forever, I guess. And so label that on their arm or something. So I'm just going to summarize what we did today. I think we had a very, very interesting interactive session, lots of great presentations. I think we discussed the fact that heart failure is common, lots of hospitalization, costly, high morbidity, mortality, that using care paths, order sets improve outcome. And that, that first month after discharge is a high risk time. We have to do something there to try to decrease repeat hospitalization and improve compliance. As Michael said, we need to think about the big four: ARNI, beta blocker, SGLT2 inhibitors, MRAs, and try to get everybody on at least some of all of those therapies, recognizing that there are issues with coverage and you have to work around the best you can to get through that coverage. And that the cluster scheme may actually be a way for us to titrate these patients to target in a shorter period of time and improve outcomes. So that's my summary of today's discussions, and I think everybody did a fantastic job, and I really do appreciate the audience and their great questions for us. So thank you, everybody, and have a great evening.
Sandeep, quick note, the
Yes.
feedback link, the form
right,
for feedback
forgot
link
that.
is in the chat.
Yes, there is a feedback. I apologize. Thank you. In the chat, if you could fill out the feedback form. There's still 100 participants, so click on that form and fill it out for us. Thank you.
I will also follow up with everyone via email, and we'll send it out as well, just in case. So if everyone could please fill it out, that would be greatly appreciated.
And we will
if there's offline questions or concerns, certainly feel free. Wide open. Want to hear what we got wrong, and don't hesitate to email or directly say to any one of us. Certainly, if you want to pick on me, no problem.
And it's Michael, great input from all of you. It's just a spectacular evening. Thanks for all the effort you put in.
Yes, definitely. Thank you.